I'm Abner Mason, and I'm founder and CEO for ConsejoSano. And I want to thank Acumen for the opportunity to talk with you about ConsejoSano and the journey that led me to start the company. If I had to pick a point which put me on the trajectory that led me to create ConsejoSano, I would say it was one day in 2001 when I was Chief Policy Advisor for the Governor of Massachusetts. I got a call from the appointments staff at the White House. George Bush had only recently been sworn in as president, and although I worked for a Republican, it was a Massachusetts Republican. My boss was no George Bush. So the White House staff told me I was being appointed to PACHA, the Presidential Advisory Council on HIV and AIDS. The council's purpose was to advise the president and the administration on ways to address the HIV/AIDS epidemic. I did not consider myself an expert on health issues, so I politely declined the appointment to this part-time position. About 1 minute later, I got a call from my boss, the governor. She called me to her office and she gave me the old baseball team analogy, which ended by her saying, "You're a player on this team. You don't get to decide what position you play. Call them back and say yes." I did. And as a result, my life changed in ways I could never have predicted. I was appointed chair of the International Committee. I knew that, the International Committee for PACHA, and I knew that US leadership was really desperately needed in the fight against the epidemic. So I thought, let's see if I can be part of making something happen. The president proposed PEPFAR, the President's Emergency Plan for AIDS Relief, during the 2003 State of the Union. At the time, it was the largest healthcare-related humanitarian relief effort ever proposed. The plan provided life-saving antiretroviral drugs to people infected by HIV in 15 developing countries, mostly in Africa. I wanted to do more to make PEPFAR a reality. I decided to create a not-for-profit called AIDS Responsibility Project, or ARP for short, and to initially focus on helping get PEPFAR passed by Congress. My first project with ARP was a congressional staff fact-finding trip to Africa. This is a picture of community health workers in Uganda about to leave for that day's ride to deliver antiretroviral drugs to individuals and families like the one shown here. They deliver the drugs out to people who live in the bush by motorcycle. PEPFAR, as you know, was ultimately approved by Congress and has funded the scale-up of programs like this, which is saving millions of lives. I hosted another congressional staff trip, this time to Mexico, Jamaica, and Brazil. We held focus groups with people living with HIV and found that workplace discrimination was the biggest source of problems related to HIV in that part of the world. At the time, people could be fired or not hired if the employer thought they were HIV positive, or in some cases, if the employer thought they were gay or lesbian. Given that some of the companies engaging in this behavior were large American multinationals, I thought to myself, we're a tiny little nonprofit, but I think I can do something about this. So we convinced 35 American multinational companies to join us in launching CONAIS, the Mexico Business Council on HIV and AIDS, which committed them to taking specific steps to eliminate workplace-related HIV/AIDS stigma and discrimination. But what about the US? This work in Mexico caused me to think about how the US health system was meeting the needs of the growing Hispanic population in the US. And the answer to that question is and was very poorly. And I learned pretty quickly that this problem is not limited to Hispanics. Our healthcare system in the US is just not equipped to serve multicultural and financially vulnerable patients in general. It's impersonal, inconvenient, unresponsive, and confusing. And that's true for native English speakers as well. The result is that a disproportionate number of people wait too long before seeking medical care, and then they engage with the healthcare system at much more expensive points than would be necessary, if they engage at all. And this is a real and growing problem because, as you can see from this slide, America is on the way to becoming a majority-minority country. According to the US Census, this will happen in 2050. But in some states, that future is now. For example, California is already a majority-minority state. So is Texas. This is huge demographic change. And as it continues to take place, not everyone is prepared to embrace it. That's the understatement of the night. But this is the America we've become. And our healthcare system has to change so that it can better serve all the people who call this country home. I created ConsejoSano to help bridge this gap. We are a patient engagement platform that helps healthcare providers and payers engage with multicultural patients to create value and savings for both the clients and the patients. Today, we serve patients representing about 20 different cultures across 5 states. ConsejoSano connects with hundreds of thousands of patients, and that number keeps growing. So what's our secret sauce? We balance tech and touch to meet patients where they are. Our tech is a spectrum of services, but our bread and butter is text messaging, which is how the majority of the patients we interact with prefer to be contacted. We've built a member insights platform that takes text messaging and integrates machine learning technology to create culturally appropriate chatbots capable of engaging multicultural patients at scale. We also use our technology to micro-segment patient populations for optimal engagement. Take, for example, a diabetes adherence campaign that we might run. In this case, one segment might be young adults who are culturally Vietnamese. They live more than 10 miles from the clinic, and we know they can't afford to pay for the supplies. Or another segment might be elderly Filipino adults who aren't doing foot exams and haven't gotten a kidney function test for the last 12 months. A constant challenge for us is to get the right balance between technology and human touch. Working mostly with Medicaid and low-income patients, we take a different approach to engaging with these folks. We don't translate. When we start to serve a new patient population, we start with culture. And by that we mean who they are, where they live, where they come from, what they fear, what they hope for, what they believe, and why they believe it, what they want for their kids. In short, their culture. And it can look a little like this slide, which shows some cultural detailing we did for a client in San Diego County in California. For example, for Iraqis, many of the folks who are from that culture believe medical services should only be accessed for medical emergencies or severe pain and serious illness. And Mexican immigrants, for example, and this is true for even second and third generation Mexican Americans, they can often believe in what they call fatalismo. That is the belief that an individual can do very little to alter their fate. In these cases, loyalty to family may supersede individual needs, and so can cause people to delay treatment, sometimes with catastrophic results. So we start with culture. When we begin, we, as I said, figure out who these people are. Then we design content based on who they are to engage them. Then we layer in the language that they prefer, and then we add in the mode of communication that they want to be communicated with. So let me give you a couple of examples. Meet Juan. From our experience engaging Hispanic patients, along with the cultural insider knowledge that we have gained through our colleagues, as well as the research we've done, we know that patients like Juan often won't go to the doctor unless they feel ill. Preventive care, going in when you're not ill, is something that's not typically done in Latin America. So a message to Juan looks like this, and it's really designed to educate Juan that a regular doctor's visit is really essential for diabetics. This is Anna. Anna is a first-generation Hispanic American. She was born and raised in San Diego, but her parents are Guatemalan. So she grew up speaking Spanish at home and immersed in the Guatemalan immigrant culture. She spoke Spanish at school, English at school and grew up translating for her parents. So she prefers that we contact her in English. But while the message is in English, it pushes back against fatalismo, that Hispanic idea I mentioned earlier, that fate is fate and nothing can be done about it. So in short, at ConsejoSano, our process is culture, content, language, and then mode of communication. And taking this approach, we are able to build trust, which leads to very high engagement rates. So the patients we work with who previously did not go to see their doctor now do. We're getting great results for our clients, and we're on track to serving 1 million patients by the middle of 2019. And like all startups, early stage companies, we're raising capital. So you investors out there, come and find me afterwards. I'd love to talk to you. So while we're growing, and it's exciting that we're growing, we're not growing fast enough. And I believe a major reason for that is the constraints that exist because of outdated laws and regulations in the Medicaid program. These old and outdated policy and regulations make it hard for innovative companies like ConsejoSano to scale our solutions. So as a side project, I have created Health Tech for Medicaid, or HT4M. It's an organization of CEOs of venture-backed companies building solutions to improve the health of low-income Americans. 35 other CEOs have joined Health Tech for Medicaid, and we're launching it in Washington, D.C. in November. I believe that Health Tech for Medicaid will help ConsejoSano, my company, and all the member companies to scale our solutions faster, which means low-income Americans will not have to wait to benefit from the amazing solutions that our companies are building. Today, less than 1% of venture capital in the US goes to companies headed by an African American. And very few investors invest in companies building solutions for minority and other vulnerable populations. That needs to change. And by investing in entrepreneurs who look like me and in companies like ConsejoSano, Acumen is leading the way. And for that leadership, I want to say thank you. There's no question that we're passing through a difficult time right now in the country, and it's easy to become discouraged. But you shouldn't. We shouldn't. Today, as we work to make our country and the world healthier and more just, we have and we can deploy better tools, more experience, more resources, and more compassion than ever before. And although you won't see it in the headlines, we are growing our numbers and our impact like never before. So when you are tempted to get discouraged, think about these health tech for Medicaid companies that are these entrepreneurs, their teams, the investors backing them. They're building solutions for low-income Americans to improve their health. And think about the Acumen family. You in this room, investors, staff, and everyone here. This is no time to be discouraged because we are just getting started. And I am so glad to be with you on this journey, and thank you for this opportunity to talk about ConsejoSano.